Hi guys, this is Charles and I am a surgeon at VetAlign, and I'm sorry if the streaming discontinued. Let's see if I can get that working now. Can you please let me know in the chat if you guys are able to see me? So this is some new streaming software that I'm trying to work out so that I can stream from my computer as well as stream the PowerPoint presentation and stuff. So please in the chat just let me know if anybody is able to see this. And sorry for the delay here. Yep, great. Okay, so I can see that some people are watching. All right, anyway, so this is my new YouTube channel, which is called VetAlign, which is kind of a continuation of VetDojo, but I'm kind of doing it on my own instead. And my purpose behind this YouTube channel is that probably 99% of the population of the planet don't have access to specialists, and so there are a lot of general vets out there that are doing it tough. And so I'm trying to provide some support, and my intent has always been to make this free of charge and just trying to give something back. Hope everybody's doing okay this morning. Please make sure that you subscribe to our channel and turn on notifications so you'll get a ding on your phone the next time we live stream. Anyway, so talk to you about a case that I had about 6 years back. This was a corgi that presented to me with a grade 2 to 3 spine, 24 hours duration of hind limb paresis. And so I see these all the time, and a long-backed, short-legged dog with hind limb paresis, you just have to assume that it's going to be a disc rupture. I've probably operated on 2,500 of these in my career. So we did a CT myelogram. This is actually not the patient, but the results would have been very similar, and we can see a large disc rupture. Sorry, let me just change to the presentation. Okay, so going back a slide. So this is a corgi that had a grade 2 to 3 spine, 24 hours duration of hind limb paresis. And so again, very, very likely to be disc disease. So we did a CT myelogram where we can see a large disc rupture right here. At the L1-2 position, you can see some sclerosis of the vertebral end plates, big bulging disc with compression of the spinal canal. And so I took it to surgery, and again, I've done probably 2,500 of these. We are burring away the lamina. There are plenty of these on the old YouTube channel in VetDojo. We're using a burr that spins at 60,000 revolutions per minute, and we're just taking the bone away from the lamina and exposing the spinal cord in order to remove that disc material. Now you can see here that I have two hands on the drill, and that's what I always tell my residents, is that they always have to have two hands on the drill at all times, and that's the way that I've always done it. And just for some reason, in this case, I think I was scrubbed in by myself, and it was bleeding excessively, so I decided to hold the suction in one hand and the burr with the other. And I had already exposed the spinal cord, gotten all the disc material out, and I was ready to close, and then I just thought, at the last minute, I'm just going to burr a little bit more underneath the cord in order to get a little bit more disc material out. And because I was holding the suction with my left hand and the burr with my right hand, the burr bit into the bone and skipped and impacted the spinal cord, and took a chunk about 5 millimeters long, about 3 millimeters wide, and 2 millimeters deep from the spinal cord and through the dura and everything. And I knew instantly that that dog would never walk again. And that kind of thing, that kind of catastrophic event has happened to me, maybe 5 times in my career, and I estimate that I've operated on about 30,000 patients. And so it doesn't happen often, but when it happens, it's just absolutely devastating, and you literally, your knees go weak, and you wish you could be anywhere else but in that theater. This is not the patient's spinal cord, but this is what I'm sure his spinal cord looked like within a couple of days. And so we recovered the patient, and he had no deep pain sensation, as I suspected, and he died about 2 weeks later from the complications. And so I took a dog that was basically walking before surgery, should have had an outstanding prognosis, and I paralyzed him and killed him. And obviously I was devastated. And so collectively, this idea is called second victim syndrome, and the title of this talk is bearing the brunt, second victim syndrome, bearing the brunt of surgical complications. This is something that I've looked it up in human medicine, and there are several hundred articles in human medicine about second victim syndrome, and there are only about 3 articles in veterinary medicine that even mention the topic or the concept. And so just note that during this presentation, just keep in mind that I'm not a solicitor or a lawyer. I'm not a mental health professional, and so the opinions that I'm giving you are my own, may not apply in everybody's situation. And certainly if you have a challenging case or any other mental health questions, seek legal and mental health advice. So basically what I'm telling you is the way that the observations that I've made along the way and the way that I tend to respond to this type of situation. So there's a saying, good judgment comes from experience, and experience comes from bad judgment. And I've got a lot of experience. So I've made a lot of mistakes along the way. You know, I'm hoping potentially through this channel and through some other avenues that I can help other people not make the same mistakes that I have. So I know how I should deal with complications, which is objectively and doing exactly what's right for the patient. But how I deal with complications is I battle with self-doubt, imposter syndrome, low self-esteem, guilt, anxiety, crisis of confidence, depression. I worry about my reputation. I think about retirement, and I'm at an age now that I probably could retire if I wanted to. But I still, most of the time, still love my job, and so I still think that I find it very motivating and exciting for me to do the job that I do, and so I'm glad that I have not retired yet. But collectively, all these issues are called second victim syndrome. And so the first victim is the primary patient. So the first victim is the primary patient. The second victim is the clinician, and then the third victim is the team. And we have to remember that the team can suffer from these situations as well, even though they're not directly responsible. So when I put this presentation together, I really started brainstorming and thinking about complications that I've either caused or observed or had colleagues experience or helped manage on a referral basis. And so basically, if you can do it, I've done it or I've seen it. And I posted on the YouTube channel a question about people listing some complications that they've seen or experienced, and just so that people don't feel alone and understand that these happen commonly. And it's been really nice because people have posted a few different complications that they've experienced, and I have to be honest with you that I haven't seen one yet that I haven't experienced myself. So just know that you're not alone out there, and that we all do see complications like this. And I just have a note in the chat from Sebastian in the UK at 2 a.m. So I'm really chuffed and excited and inspired by you staying up till 2 o'clock in the morning to see this thing. So when I think about second victim syndrome, I started thinking about things that make it worse for me or really exacerbate those experiences. And the main one for me, or not the main one, a common one for me is if somebody else has to clean up my mess. So if I come in on Monday morning and find out that somebody else got called in on their day off when they're on call to manage one of my complications, I find that really challenging. And so an example would be that I had a cat that I operated on and did a pelvic fracture repair, doing what I thought was a perfectly acceptable repair. And then on Monday morning, about 10 days later, I came in and found out that my business partner at the time had to come in on the Saturday and revise the fracture because it had fallen apart. Another one was that I had a dog that I did an abdominal exploratory on. About 3 months later, it came in with abdominal pain. They did a CT scan and an exploratory and found a sponge that I had left in the abdomen. And, I've done that once in my career. Actually, I've done it twice in my career. Once as a resident and then once again about 6 months ago. And funny thing is that surgery was live streamed. And I went back and watched the live stream and in its entirety, it's about 45-minute live stream, and I cannot find the point at which I left that sponge in the abdomen. And I watched it, I've watched it really, really closely over and over again, and I still can't see where that happened. And I guess it's possible that it could have been left in from another previous surgery, but it was our brand of laparotomy sponges, and the dog was a male and had not been spayed, so nobody had been in that abdomen before. So basically it has to have been me. So somebody else having to clean up my mess really exacerbates my feelings of guilt and shame. That brings up a question of, do you call or do you contact the primary case owner after hours? So say, for example, you're on call and you come in on a weekend and you have to see one of your colleagues' cases because it has a complication. And, should you call them and contact them and let them know that case is in? And in favor of that would be that you feel, the clinician's going to feel worse if they come in after the weekend and find out that somebody else had to manage their complication. But on the other side, I think that time off is really important, and a phone call like this can certainly ruin a weekend. So if I find out that I have a complication on a Friday, for example, it's entirely possible that the next week for me is going to be pretty dark. And so I believe that our time off is really important. So my policy on this kind of thing is to always spare that clinician if they're not on call, and just tell them when they come in next and when you see them next, just to preserve and kind of to make that time off that they have kind of sacrosanct, so that they can enjoy their weekend or whatever it is, and then just deal with it, and then they come back in. Now, on the other side of things, if you are on call and there is a complication, my feeling is that you should just go in and see it. And sometimes I'll get a phone call at 2 o'clock in the morning saying that one of my patients isn't doing well. And my wife is equine internal medicine specialist, and I'll be laying there answering some questions at 2 a.m. and I'll say, yeah, just take an x-ray or whatever. And all of a sudden I'll get a sharp elbow to my ribs. And my wife says, you have to go in and assess that patient yourself. And I'll go, ugh, okay. And I pack myself up and head in, examine or examine the patient. And what I find is that owners can handle a difficult phone call much better when it's made cage side than when it's made from your home. You can better assess the patient. You're going to sleep much better afterwards when you do finally get home. And if things go pear-shaped and you didn't go in, it looks really bad. And that point really comes to mind because my dad, I'm sure some of you know, was a thoracic surgeon. And one of the events that resulted in his retirement was that he had a patient with a chest tube in, and he got a phone call at 2 a.m. and they said the chest tube was leaking, and he didn't go in. And then at 5 a.m. he got a phone call saying that the patient was in cardiac arrest, and he got sued. And that was one of the reasons why he retired. So as hard as it is to gather yourself up at 2 o'clock in the morning or to come in on that Saturday afternoon, just remember that somebody else will be doing that for you when they're on call. And for your mental health, you're going to feel a lot better having gone in, assessed the patient, managed it, contacted the owners, and then come back to bed. So that's kind of my opinion on it. Now, that brings up another topic. I find it interesting that when I have to clean up somebody else's problem or somebody else's mess, it's so much easier to focus on what's best for the pet and on effective communication. So you don't have any issues with guilt and shame. Your thinking is crystal clear. You think, okay, we've got an infection, we're going to have to culture the wound, maybe open it up, flush it out, put it on antibiotics. Whereas if you're dealing with the guilt and shame and trying to manage the client's finances and stuff like that, you might not say what actually is the best thing for the patient. And so what that tells me is that there are issues at hand more than just the well-being of the patient. And when you have guilt and shame clouding your judgment, you might not always make the best decisions. And And the other thing that comes to mind is that when you do have a complication, that you discuss it with a colleague to try to get an objective opinion on what you should do. And I really believe that if somebody comes to me and has had a complication and I can see an obvious point at which they did something wrong, I'm going to tell them, and I'm going to be very transparent, very supportive and non-judgmental, but I'm going to say, look, in my opinion, maybe if we had done this differently, it might not happen again. And the whole idea here is not only to manage the current patient, but also to try to prevent the situation from happening again. And I had a vet who found me on my YouTube channel probably about 3 years ago, and they sent me a post-op orthopedic repair and said, "Oh, what do you think of my repair?" And I looked at it, and I all I could think of was, this is just really bad, and it's the patient's gonna, the fracture's gonna fail in about a week. And I responded and I said, "Look, this is what I think is going on, and this is what I think you need to do. I would not let that patient go home from the hospital." And that person took my criticism really well. And then the next day sent me another radiograph and said, "How about now?" And I said, "No, that looks really good. I'm happy with that." And this person continues to send me radiographs. And over the last 2 to 3 years, I have found that their repairs are getting better and better, to the point that often when they send me a radiograph, I look at it and go, "Yeah, I think that looks great." And so that's a real inspiration for me to see this person take constructive criticism and to act on it, and has really changed the way that they do things. And so that's, yeah, I think that that's just great. So again, the whole point not only is to manage our mental health, but also to try to keep these complications from happening again. And I see Nicoletta from Romania, which is probably about midnight, I would imagine, there. So I appreciate you staying up and watching this. One other observation I've made is that timing is everything. And if I have a complication at 8 o'clock in the morning, and then I know that I'm going to be meeting the client at 4 p.m., that day is very long and challenging, and I'm just mulling over what I'm going to say to the client and how they're going to respond. I find that often immediately after that first discussion, particularly if I've been completely transparent and have a good plan going forward, I feel so much better. And so my recommendation in that case is to get that conversation done as soon as possible and to be completely transparent. That's like when I was a business owner and a nurse would come up to me and say, "This is at 9 o'clock in the morning," and he or she would say, "Can I have a chat with you this afternoon?" And I go, "No, right now," and let's go straight into a consult room and get this out of the way. So I don't deal with the stress of knowing that I've got a challenging conversation coming up, and so I would much rather get that conversation out of the way as quickly as possible. Nicoletta from Romania says that it's 4 a.m. here. I have my maths wrong, so thanks a lot for staying up and watching. The other issue that comes to mind is family, friend, or staff pets. What I find is that these patients seem much more likely to suffer complications, and I'm sure that everybody would agree with that. And the problem with these patients is that they're often brought in the back door, and that means that they don't have a proper consult. They don't have a proper consent form or an estimate signed, and then when you have a complication, the team member or the friend or the staff member is not properly prepared for what's going to happen when there is a complication and how likely the complication is to happen and that kind of thing. So that guilt and shame can be amplified when you're dealing with complications in a familiar pet. And again, it seems like those clients or those pet owners are not properly prepared for the advent or the incident of a complication. So I will talk about how we manage those a little bit more in the presentation. The other thing that really exacerbates or amplifies the issue for me is gossip. If I think that other people are talking about me within the practice and discussing my complication and the fact that I'm incompetent, and I don't know that that ever really happens, but if I get that perception that there's gossip about it, my stress, shame, and guilt are massively amplified. And I think that gossip is one of the corrosions in a vet practice that seems to be most significant to me. And so gossip erodes trust, strains relationships, reduces collaboration, and makes for a more toxic work environment, damages reputations, results in a culture of negativity, hinders productivity, increases conflict, and undermines morale. And if there's one thing that I think people should really try to get rid of in their veterinary practice is gossip. And I will talk about that a little bit more in our solutions section. The other issue that really amplifies for me my stress and shame and guilt and that kind of thing is when there's a significant financial impact on the owner. If I have a patient that's insured, it's much easier because you can just say, okay, it's clear we need to do this and this and this, and it's not going to result in any financial impact on you. But if the patient is uninsured, then you might have had somebody that came in and said, I've got $5,000 for this surgery and I have no more money, and you take their money and you do the surgery, and then you have a complication that results in another $2,000 to $3,000 in expenses. And how do you manage that, particularly if you're not the owner of the practice and you're trying to make concessions for them and that kind of thing, and that can really add to the stress that you feel when you're dealing with these. The other issue is, was the preoperative communication as complete as it could be? And the classic example, which I think all surgeons are guilty of, is the blasé, overconfident surgeon. And some of you may have heard the story of my dad, who was, again, a cardiovascular thoracic surgeon at the time, and about 4 months before my wedding, went on his first holiday in about 30 years, and he was in France and had a stroke while he was there. And so he was put on an airplane, came back to America, where I was living at the time, was admitted to his own hospital and had an argument with the radiologist. Note that he was paralyzed on his right side of his body and couldn't speak because the speech center is on the left side of his body. So he couldn't speak and was paralyzed, so he couldn't write because he was right-handed. And he's arguing with the radiologist about the fact that he believes that he's got a lesion in his middle cerebral artery. And the radiologist didn't believe him, and so he put himself on an ambulance to the Mayo Clinic in Jacksonville and ordered his own MRI, which confirmed the fact that he had a 90% of occlusion of his middle cerebral artery. And so I went down to meet with the neurosurgeon, and I said, so what's going to happen? And the neurosurgeon said, well, we're going to cut a hole about 6 centimeters in diameter in his skull, and then we're going to take the 2 millimeter superficial temporal vessel, and we're going to dig a tunnel 6 centimeters deep in his brain and anastomose this 2 millimeter vessel to the 2 millimeter middle cerebral artery deep in a hole in his brain, and restore circulation to his brain. And I said, wow, that's incredible. What's the prognosis? And he goes, oh, he'll be operating again in 2 months. And I said, no, what's the mortality? And he goes, there's no mortality with this surgery. So that is your classic overconfident surgeon. And I think for some of those things, those surgeries, particularly the ones that humans do, I think you have to have that kind of confidence in order to even get in there and try it. But we do have to make sure that we do explain potential risks to the clients with enough urgency and sincerity that people actually understand that, well, most of the time things go well. There are times when they don't go well. The other big one that I experience is when I have like another specialist in the hospital in internal medicine, for example, come to me and say, we need you to do an exploratory on this dog, and I don't actually talk to the owner directly. And so those cases, again, seem to be more likely to have complications, and the clients haven't been adequately prepared. And so I believe that whoever is doing the surgery needs to call the owner. If you have a practice where one veterinarian admits a patient and then they're too busy and it gets passed on to another veterinarian to do the actual surgery, I think that the person actually doing the surgery needs to call the owners beforehand and say, look, this is Charles, I'm just introducing myself, I'm going to be operating on Tiger today, and these are I'm sure that they've gone through this already, but these are the complications that I worry about, and then document that conversation in the record to make sure that that everybody's on board. So really important in that regard. So what changes can we make at the institutional or at the practice level to try to mitigate these second victim syndrome issues? And so what we're trying to do is we're going to try to limit the frequency of complications, limit the damage of complications, improve our patient outcomes, improve our owner outcomes, and most importantly in this lecture is improve clinician outcomes so that we don't have that emotional suffering that we go through when we have complications. So I really advise you to create a complication management checklist. And what that is just a list of things that you're going to go through when you have a complication to make sure that all the communications are complete, and that if there is something to learn from that complication that you can apply to other cases in the future, that has been documented. And so general demographics on the case, the patient name, patient owner phone number, what procedure was done, date of the procedure, and then who the primary clinician was and what the complication description was. And so what I advise you to do is that if you have a smartphone, you can use like Google Sheets or something like that, which is an Excel analog, and just create a column for each of these questions, and then on every complication that you have, you fill out that sheet. So other questions are, were the owners advised of this risk of complication? And if not, you need to make sure that when you do these types of cases later on, that you do include that in a potential list of complications. Have the owners made a complaint? And if the owners have made a complaint to either you or to the vet board, then you need to notify your insurance carrier, because what you don't want to happen is the insurance carrier to say 6 months down the road, oh, we're not going to cover you because if you had notified us about this 6 months ago, we might have told you how to manage things differently. And the insurance carriers, certainly in Australia and in the US, are really good, and I can't imagine that they would actually do that, but we need to make sure that we notify them as soon as we can. What usually happens is when you notify the insurance company, they'll send you a form for you to fill out and describe the complication, and then often nothing will happen, and then 6 months later the insurance company will contact you and say, look, we have this case open of this complication that you suffered or that your patient suffered. Has anything happened with that? And the usual response is going to be, no, nothing's ever happened. And then they'll say, okay, we'll close the case now, but if anything changes, just let us know. And that means that you're opening up that documentation so that the insurance company can act on it if they feel like they need to. One important question is which clinician is taking over the primary management of the complication, and I will discuss that in more detail a little bit later on. What were factors contributing to the development of the complication? Were there any human factors involved? Were there environmental factors? Were there policies and regulations relating to the complication? And if so, were they followed? And so if you have a complication, let's say, for example, the pop-off valve is left open or left closed on an anesthetic machine and a patient suffers barotrauma, you might have a policy in your employee manual. And if you do have a policy about leaving the pop-off valve open, why wasn't it followed? And so there are three reasons why policies aren't followed in a hospital. Either the team member doesn't know about them, the team member, it was difficult for them to carry out the policy because of time constraints, or all the equipment wasn't available or whatever, or they didn't want to. And if they didn't want to, you need to find out why. And it's rarely because there's a team member that's just trying to sabotage your practice. It's usually because of a lack of availability or lack of knowledge or that kind of thing. And then, was a transparent explanation given to the owner? Is there a clear plan going forward? If the complication was the fault of the practice, have they admitted responsibility? And then if there was a problem on the part of the practice that resulted in the complication, have any institutional changes been implemented so that keep this from happening again? And also the owners really like to hear if there's a complication that their pet suffered because of fault of the practice. They really like to hear that you've made changes to keep it from happening again to other patients. And then the other question is, has a partial or complete refund been offered to the owner? And I'm a big believer that if a refund is going to result in a happy client or a relatively satisfied client, and it means that you don't have to go to the vet board, I think that that's money well spent. And you certainly can put a proviso or a waiver saying, look, we're not admitting guilt here, we're just doing this as a professional courtesy. And often that will diffuse a really irate client. And the other really important question is, has an explanation for the complication been provided to the team? We have to remember that we work with a lot of health professionals, even if they're just kennel assistants or nurses, junior nurses, senior nurses, or whatever. They often suffer emotionally when you have a complication or a poor outcome, and often they don't understand why the complication happened, and potentially just that the patient was really sick, and that's the way some of these things go. But they need to be trusted, and to know that you're investing in their knowledge and understanding, and that can go a long way in reducing gossip in your practice. Regarding familiar pet owners, so that's the team, family, and friend pets, you need to treat these owners like normal clients with a proper consultation, sitting down in a consultation room, given a proper estimate, and sign a consent form. Because we often have heard that vet nurses feel like they're kind of swept under the rug when their pet has a complication, and that they aren't treated with the urgency and the completeness that paying customers are treated. And remember that your team members are your biggest advocates and your biggest advertisement when you treat their pet and things go well, and they're treated like a normal client. So I think that that's a really important aspect, and that should be part of your checklist, making changes in your practice to make sure that familiar pet owners are treated like normal clients. Regarding mental health support, normalize checking in, and that means that if you are suffering from guilt and stress, that you tell people in your practice and say, look, I'm really struggling with this. This really upset me, because there's a concept of leader without a title, which means that in your practice, you are definitely going to be a leader whether you are a titled leader or not. And that means that junior team members and nurses are going to look up to you and look at the example that you set. And by showing mental health vulnerability, it's going to show them or tell them that it's okay for them to be suffering or struggling as well, and to verbalize those concerns. We need to provide support, training, and opportunities to explore emotional demands. And if you have team members that are interested in becoming mental health officers in your practice, that's a really great thing to do to increase awareness. And it also takes some of the workload away from you. The other big thing is, again, to lead by example, showing vulnerability when discussing mental health issues. And so I have generalized anxiety disorder. I was diagnosed about 15 years ago, and I've been on serotonin uptake inhibitors for the last 15 years, and they changed my life and literally saved my marriage. And I believe that some mental health issues are just a chemical imbalance in your brain. And if you're a diabetic, you would take insulin. If you have a lack of serotonin in your brain, you take serotonin uptake inhibitors. There's no guilt, there's no shame associated with that, and it really can be a life-changing decision. And so I think that showing vulnerability, I don't hide that fact from anybody. I tell my team, I tell my family members that I'm on a mental health plan, and I think again that leadership can go a long way in this industry where mental health is such a big concern. The NTSB is the National Transportation Safety Board, and that's the board that investigates all airline crashes in the United States. Actually, not just airline crashes, but even near misses, also train crashes, anything that involves public transport. And the purpose of the NTSB investigation is to find out what happened, with its primary goal to make safety recommendations to try to keep it from happening again. And so what they do is they'll investigate an accident, and they really encourage transparency and lack of judgment. And so if somebody feels like something was their fault, they need to feel free to point it out and say, look, this is what happened, and I believe that I caused this. And what they do to ensure that people are transparent is that the findings of the NTSB investigation are sequestered from the court of law, which means that the lawyers cannot take that information from the NTSB investigation and sue the airline or sue the pilot or anybody. And that sequestration has been upheld in Supreme Court numerous times. And so the Supreme Court feels like the sanctity of that process and the transparency of that process is so important to improving the safety of everybody else going forward that ever gets on an airplane or a train, that they've upheld that sequestration from the court of law. Same thing with morbidity and mortality rounds in a hospital. It's critically important that that process be transparent and that people feel safe to self-report that you cannot use that information to sue the hospital or the doctor or the airline or whatever. Next thing that they're going to do is examine human factors. Where there was an individual's action responsible for it. Was it a mechanic that didn't adequately tighten a bolt? Was that person adequately trained? And was fatigue a factor? Were systems being maintained properly, or was did a piece of equipment fail that resulted in the accident? What were the weather conditions and did that contribute? Were there existing policies and regulations? And if there were policies and regulations, were they followed? If they weren't followed, why not? And again, this is not a disciplinary process. It's purely a fact-finding mission to try to prevent it from happening again. And then they're going to identify contributory factors, why it happened, and to make safety recommendations going forward. Because again, the whole purpose of this investigation is to make safety recommendations to keep it from happening again. Same thing in human morbidity and mortality rounds. You want to do a structured case analysis, involve multidisciplinary team members if possible. And so you want people from all levels, the nurses, the receptionists, the kennel helpers. If it was an anesthetic death, maybe get the input of a specialist anesthetist and just ask him maybe to look through the medical records and then present that at the Eminem rounds. Eminem rounds need to be transparent and non-judgmental, very supportive. You need to summarize the findings for the whole team, disseminate the outcomes, and then institute changes if it's appropriate. And just in the chat, can you guys tell me if you do Eminem rounds in your practice? Because that's a really great opportunity for learning. So just put in the chat if you do Eminem rounds in your practice. I believe that any team member should be able to request an Eminem review, and that means that even if it's a kennel helper, a kennel assistant that's upset about an outcome, they should be able to request a review of what happened to that patient. And so just remember that team members can be adversely affected as well. That's the third victim syndrome. And often it just reflects a lack of understanding of the pathophysiology in the literature. And maybe team members don't understand that a patient that's in heart failure and kidney failure often has a good chance, a high chance of dying. They might think that it was the neglect on the part of the clinician, when in fact it's just the physiology of the problem. And when you tell them that, and acknowledge their concerns, it's going to show that you're investing in them so that they can use that information to help them in the future. It also shows that you're investing in their education, and acknowledging their concerns are going to reduce the tendency toward gossip. That brings up the other issue, is that you need to establish a zero tolerance for gossip in your employee manual. And I guess the other issue is that if you don't have an employee manual, you really should have one, because when you're expecting a certain behavior from your team members, you need to be clear with what that expectation is, so that you can say, if you come in on a conversation that is clearly gossip, you can say, look, it's clear in your employee manual that this is not acceptable behavior and we don't tolerate that around here. And below the line behavior must be called out by all team members. So again, if you walk in on a conversation that's clearly gossip, whether it's about a particular case or it's about who's married to who or who's seeing who or whatever, that kind of conversation in a practice is very erosive and counterproductive. And so when you walk in on that conversation, you need to say, look, that's not acceptable conversation in our practice. And if you have a problem with the person involved, you need to go and talk to them directly and not have this lateral little chitter chatter going on between team members. And if you think that the problem is bigger than that individual, you need to go to the practice manager or the senior team member. And then, of course, lead by example. So don't participate in these gossip type conversations in your practices. You need to provide good mentorship of junior doctors, and you can't expect junior team members to operate outside of their comfort zone. And an example of this is that about 10 years ago, we had a referral to us, which was peritonitis in a dog that had an ileocolic anastomosis for a corncob foreign body. Now, we did the surgery and the patient did really well, but in the medical record, the person who operated this on the patient was only about a year or two out, and she wrote all over the place in the record, I'm not comfortable with doing surgery. This is out of my comfort zone. The boss is making me do the surgery. I don't want to do it. And then it failed, predictably. And that person, luckily, number one, documented in the record to cover themselves. But number two, that boss that was making that team member operate outside of their comfort zone was the president of the vet board at the time. And that person was making judgment on other people and how they manage their cases. And I think that that is, talk about leading by example. That is just a really terrible example of how not to behave in your practice. We need to provide a supportive learning environment and mentor people through new procedures and be right at the table side with them, helping them place every single suture, or if they're really uncomfortable, not forcing them to do it. We need to provide support when team members make mistakes and promote a culture of safety where junior team members feel safe to point out concerns and also to self-report when they make mistakes, knowing that they're not going to be disciplined and that they're going to be supported. And then also mentors showing examples of vulnerability when seeking help for mental health issues. So again, we want a culture of safety, which we have to acknowledge the fact that we work in an industry where mistakes happen. And I've heard a statistic that when a patient is admitted for surgery in a regular vet practice, that about 1,000 things have to go right for the patient to have a successful outcome. And we don't realize how many little steps and little minutiae has to go perfectly in order for things to go well. And so we need to admit that or acknowledge that there's risk, that individuals can report errors and self-report errors, and that the organization has a commitment to collaboratively implementing systemic changes to prevent future errors. There's a crazy statistic, which is in the 60s and 70s in aviation, there were team members that were so afraid of being yelled at that they'd rather keep their mouth shut and crash and die. Okay, so flight attendants that were so afraid of getting yelled at that they didn't point out an error, knowing that that error was likely to result in a plane crash. And that culture is just a huge poison in your practice when people are so afraid of pointing out a problem and a fear of getting yelled at that they're going to keep things to themselves. So the other thing that we need to do is make sure that we have a thorough and transparent discussion with owners about complications and expectations. So this is not just forms to sign, but a proper, complete discussion about potential risks and realistic expectations for outcomes. And I know that as a surgeon, when I want a surgery to happen because I'm excited about it or it's a new procedure that I'm trying to do, sometimes I tend to glance over the complications and say, oh, this has been reported, but it doesn't happen very often. What we need to say is that, in this situation, there is a 10% chance that we're going to have a failure of the repair or something like that, and be very, very transparent with owners. Now, this is a consent form from Southpaws, my former practice, which is basically lists every potential complication known to man. And what you do is that this is the template, and then you just erase the complications that don't apply. And so, for example, if I'm doing an oncology procedure, I'm going to list anesthetic mortality, infection, and then metastasis, local recurrence, wound breakdown. If I'm operating on doing an anal sacculectomy, I'm going to list incontinence as a potential risk. And these percentages should be based on the literature. And so with a routine anesthetic, we know that the anesthetic risk is about 0.1%. and risk of infection with a sterile surgery is 2.5%. And if I'm doing a curative intent surgery for cancer, my local recurrence rate is 5%. And the risk of metastasis, for example, with an osteosarcoma is 95%. So you need to know all of those percentages. The other thing that we do is we create templates for a TPLO, for example, which is pre-filled out with all of the percentages for anesthetic risk, infection, continued lameness with a TPLO is 5%, meniscal injury is 3%. Neurologic injury is not 0 with a TPLO, but if you're doing a pelvic fracture, for example, maybe 5% of dogs are going to suffer a sciatic nerve injury. Implant failure, if you're doing a patella luxation, what's the risk of recurrent patella luxation? And just be very, very direct, using evidence-based knowledge to explain to the client what the potential risks are of this particular surgery. Creating an active, complicated case log. And so using that spreadsheet that I talked to you about before on Google Sheets or on Excel or Numbers if you have a Mac, and just list every complication. And the idea is that every complication or near miss is logged. It allows easy access for follow-up so clients don't feel abandoned. So you can just go back and look at your case list and see, is it an active complication? If that is a yes, then you need to call them every week or two until you can change that to a resolved, meaning that the complication is completed or finished. Also, it allows trends to be identified. Are you having nosocomial infections? For example, I had 17 Pseudomonas infections in my practice in 1 month. And we found out that we had Pseudomonas growing in our sink and that our suction tubes were not being adequately processed and that there was still biological material in the Fraser tips after sterilization. So having a log like this is going to help you identify those nosocomial infections, or, we've had batches of suture that were bad and resulted in multiple dehiscences. And again, you want to be able to pick that up quickly. It allows or assists in learning and making positive changes in protocol, because ultimately what we're trying to do here is keep these things from happening again. So this complication management checklist is going to help provide structure for complication management when emotions are high. And I always find that when I fill out that checklist, I always feel so much better because I know that the care is going to be consistent, I've communicated appropriately, and it gives me peace of mind knowing that all the bases are covered. And so that goes a long way from mitigating my second victim syndrome when I complete this checklist. Again, we want to promptly notify the insurance carrier if the client makes a complaint, or if you get any hint that this client might form a complaint, just quickly give your insurance carrier a phone call to initiate the documentation process, and they'll really help you out. Most insurance carriers are really, really helpful in these situations. Ideally, the primary clinician should take over ongoing care, because clients feel or resent when they feel like they're being shuffled around. And if the rechecks are handled by the most junior team member or a different person each time that has to go back and try to read the record and try to figure out what's going on, in these complications, you really need to hand that ongoing patient care to a single clinician. That allows continuity of care. And if it can't be the primary clinician, then another clinician should take charge. You want to carry out an investigation if there's a complication to try to determine the cause. If it's a single infection that happens and you're not having a run of them, then you probably don't need to undergo a complete NTSB investigation. But if you are having complications that are above what is commonly reported, or if you have a complication or an adverse event, which is what they call a never again or never again event, like if you operate on the wrong leg, or if you have a patient death under anesthesia, or somebody leaves the pop-off valve closed, or you operate on the wrong patient or something like that. These are never events that should never have happened. And if you have one of those, you need to carry out an investigation to try to find out why that happened. So we're going to gather and analyze factual information, again, encouraging transparency, lack of judgment, and also encourage self-reporting. Examine human factors, action training and fatigue, systems maintenance, weather conditions. And I don't actually mean weather conditions, but I mean, was anything else happening on the day? Like, for example, did 3 people call in sick? or was there building construction going on, or had somebody had, for example, an epileptic, like a human team member had an epileptic seizure on the morning of, and everybody was kind of wigged out from that. And that has happened to our practice a few times before, and people are just kind of stunned, and then they may not pay as close attention to the rest of the day and the patient management the rest of the day. So then we're going to identify contributory factors, make an overall analysis, and then make safety recommendations to, again, the most important thing is to try to keep this from happening again. Now, there have been a few publications that have looked at client lawsuits and the reasons why people sued their vets. And usually it's not about the money. So rarely is it that a client just says, I'm going to make some money from this vet, and so I'm going to sue them. The number one reason why people sue their vets is because the vet never said they were sorry. And I know that the insurance companies and the lawyers are going to tell you not to say you're sorry because that admits guilt. The way that I handle it is I think of an excuse to say sorry. Even if it was nothing that I did wrong, I'll say, look, I'm so sorry that you're going through this. It must be really challenging for you, and let's see what we can do to get you through this. And I've operated, again, probably on about 30,000 pets, and I've never been sued. I certainly have had my share of complications, but just that one admission of guilt, saying you're sorry, or not admitting guilt and saying you're sorry because they're going through the situation, I think goes a long way to diffuse a client who's angry. The other reasons are the owner perceived that the vet wasn't listening to their concerns. The owner felt abandoned. The vet failed to admit responsibility, and people can tell when you're not being transparent about stuff. And even if you get away with it with the client, it really erodes trust on the part of your team members when they feel that you're not being entirely honest with the client. You need to be honest with your team members. You need to be honest with the client when there's something that you did wrong. Again, the owner felt lack of transparency, lack of continuity of care, or the vet failed to provide a plan going forward. So when clients suffer a complication, they just see this big dark tunnel with no light at the end of it. And what you need to do is come up with a plan that says, okay, we've got an infection right now. We're going to try antibiotics. If that doesn't work, in 3 days, we're going to open the wound and flush it out. And if that doesn't work, we're going to blah, 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 and blah, blah, blah. And so you need to, number one, it gives the client clarity, but it also gives you clarity about what you need to, how you need to manage this patient. So transparent communications with the owners is really, really important. And again, I say I'm sorry every time there's a complication. Even if it's not my fault, I say, I'm sorry you're going through this. Let's see what we can do to get, a successful outcome. You need to listen to the client's concerns. You need to have a clear plan going forward, admit responsibility if appropriate. And clients really like to hear that if there was something that was your fault, that you've instituted changes in your practice to keep it from happening again. Clients really love to hear that you've taken it on board and that you've admitted responsibility and that you're taking it seriously. And then again, I don't hesitate to give a refund. And sometimes if you have a disgruntled client, just have a conversation with them and say, look, what's it going to take to make this right? And they might say, I'd like a refund. And then you say, that's fine. And if it's not your practice, you should talk to your practice manager or owner and say, look, I think that this is really what we need to do to diffuse this. And if we can avoid a trip to the vet board, I think that it's worthwhile. And I've been to the vet board twice, and both times were found that there was no finding against me, but it is one of the most stressful situations to ever happen to a vet. And if you can do anything to avoid that, I think it's worthwhile. As far as communicating with the client after a complication, make sure that you call them at regular intervals to check on the progress, and that can be prompted using your case log of adverse events. The other thing is that if I come in on a Monday morning and find out that one of my patients was euthanized or passed away on Saturday, the first thing I do that morning is to call that client, because clients really resent when you don't make that, when the primary clinician doesn't make that phone call. So that's a really important thing to do. And again, it's one that you dread making that phone call, but as soon as you do make that phone call, often you feel much better, and the client definitely appreciates it. there's a trend in human medicine toward transparency. So hospitals have found that full transparency in the face of a complication or adverse event reduces the risk of litigation. And some hospitals have even taken the preemptive step of giving monetary compensation preemptively, and that reduces the risk of litigation. Like they'll say, well, I'll give you an example. I had a friend in vet school who was at her swimming pool at the apartment complex, and there was a Pepsi machine and a slight incline next to the swimming pool, and she put her money in the Pepsi machine. The can didn't come out, and so she tried to shake the machine. The machine fell over backwards she fell over backwards with the machine on top of her. She was in the swimming pool. Her leg was trapped between the machine and the edge of the swimming pool, broke her femur, and luckily some guys came up that were passing by and lifted the machine off her and called the ambulance. And as soon as she got to the hospital, Pepsi showed up and gave her a check for $10,000 and said, look, we're not asking you to sign a waiver or anything. We just want to make the next, several weeks a little bit easier for you. Here's $10,000. And that approach in human hospitals has been shown, and I'm not saying that this is something that we should do in veterinary medicine by any means, but certainly admitting guilt and being transparent has reduced the cost of litigation in human medicine. So the other thing that's really important, again, is to remember the third victim syndrome and have transparent communication with the team, because some team members may not have the knowledge to understand that some cases go poorly, and their concerns need to be acknowledged because they suffer just like the primary clinician does. And by doing that and acknowledging their concerns is going to show that you trust them, it's going to give them more knowledge so that they can use it in the future, and it's going to reduce gossip. We need to have clear and complete documentation in our records of all communications with the clients and also the results of the investigation, because if you go to the vet board, the main thing that the vet board will ding you on is poor communication and poor documentation. At least that's the case in Victoria, Australia. So they're very reluctant to pass judgment on negligence and that kind of thing, but it's very easy for them to pass judgment on if communication and documentation wasn't complete. So make sure that you do that. And I document now every phone call with every client in the medical record. So this is a reminder. This is a pop-off valve closed on an anesthetic machine, and that is an anesthetic bag right there. And this is a reminder to tell you a story about a nurse that was in my practice, a very experienced nurse, but on one particular day, she left the pop-off valve closed on the anesthetic machine, and the patient died. And she was absolutely devastated. So that nurse did not need to be yelled at. She needed to be hugged. Okay, she felt terrible, and people in the vet profession we're all type A personalities and we're all perfectionists. And when something happens like this, you don't need disciplinary action, you need love and support. And what that's going to do is that it's going to encourage transparency and self-reporting. And we need to remember that a single event, the first thing you should think of when there's an event like that is, what did we do wrong as a practice that put this poor nurse in this situation that allowed that to happen? And so what we did when we analyzed it was that she was a bit overworked, a bit fatigued, and we needed a checklist on every anesthetic machine that said, is the pop-off valve open? Is the oxygen connected? Is there isoflurane in the machine? Is the correct bag in place? Is the correct circuit in place? Do we have soda lime adequate soda lime in the machine? And so whenever you hook up a patient to an anesthetic machine, you have to go through that checklist. And so this is a great diagram that shows that if you're having the same mistake happening over and over again, that's a systematic error, and that should be your initial response when there's an adverse event in your practice, was that it was some policy or procedure or something that your practice did wrong, not what an individual did wrong. Now, if you have the same individual making random multiple mistakes, we need to recognize that it's still that person needs love and support, but that maybe they don't have adequate training, or maybe they're not in the right role, or maybe they're not the right person for your practice. But that still needs to be treated respectfully and transparently to help that person through that situation because they're going to be suffering. Remember that you should have a zero yelling policy in your practice, and that goes from the practice owner to the senior veterinarian to the senior nurse to the kennel assistant. It is totally acceptable in any veterinary practice today for anybody to yell at anybody else. And if you are yelling at somebody, you are not in control of your emotions. You're going to make poor decisions, and you're going to make a very stressful situation that's going to discourage transparency in your practice, and it's going to erode trust. Okay, and so if you are yelling at people in your practice, you need to seek help and find out why you're emotionally so charged that yelling is your only recourse. And if somebody else is yelling in your practice with any kind of frequency, you need to talk to that person and say that person needs to seek help and try to figure out what's going on that's causing them to do that. And I have yelled in the last 20 years one time in my practice, and it was extremely challenging for the team members that witnessed it. And I immediately afterward, I pulled each team member aside and apologized to them for putting them in that situation, and also made changes to address my mental health and also to make sure that I took steps to make sure that didn't happen again. So again, if you yell at somebody, it should be a huge red flag to you that something's wrong and that you need to find help. And again, even if it's a person that's driving you crazy, you need to manage that person appropriately and not use yelling as a recourse. Now, what do you do when a team member does something right? And I'll give you an example that happened to me about 6 or 7 years ago. I admitted a patient for a TPLO, and I missed an abdominal mass on physical exam. So I did a physical exam, but it was a cursory orthopedic exam. I was in a hurry, and then my patient was being prepped for surgery, and the nurse brushed the back of her hand on the patient's abdomen, and something lit up in her brain, and she goes, "I think that feels weird." And she palpated it and found a huge abdominal mass. And she called me over in front of everybody. There are like 20 people there. And she says, "I think this patient has an abdominal mass." Now, this could have gone two ways. Number one, I could have yelled at her for pointing out my mistake and my neglect in front of my team members, and then called the owner and said, "When I anesthetized your patient, I found an abdominal mass, and aren't I amazing?" Or alternatively, I don't know if anybody watches Australia's Got Talent or Great Britain's Got Talent or America's Got Talent, but you push the golden buzzer and ticker tape falls from the sky, and you have a huge celebration and say, "Thank you so much for saving my butt. And that, you're an amazing nurse, and here are 2 movie tickets to celebrate." And that's how I believe that this type of situation should be handled. And we used to give out a lot of movie tickets to nurses that found errors and saved you from a difficult situation. And then you call the owner and you say, when your pet was anesthetized, my nurse palpated an abdominal mass, and aren't we lucky that you have a team of 30 skilled professionals and not just one overworked veterinarian looking after your pet. And give that nurse credit to the client. And the nurse is going to feel so proud that they're going to look for every opportunity to try to help you out and to try to cover you, to save your back in any situation. And rarely you'll have a nurse that just tries to point out people's errors or a vet that likes to just point out people's errors to make them look bad. But for the most part, people just want to do the right thing and want the best outcome for the pets. And so acknowledging their knowledge and ability and empowering them to help you out in these situations is going to go a long way. And I have a comment from Tony Hayes, who's here in Melbourne. Yes, I buy them flowers, which is great. So, and I know Tony's a very senior vet, and that is just an amazing response, is to celebrate when somebody helps you out rather than chastising them. So there's a saying, may we never confuse honest dissent with disloyal subversion. So people are in the industry because they love animals and they're trying to do the right thing, and you need to empower people to help you avoid mistakes. So this is an example of a human nurse in America. Her name was Redonda Vaught. She was a nurse at Vanderbilt University, which is one of the biggest medical centers in the US. And she inadvertently administered vercuronium instead of Versed. Now, vercuronium is a paralytic agent like atracurium. It's a derivative of the drug that the Amazonian people in the Amazonian jungle collect from a poisoned frog, and they tip their arrows in it, and they shoot monkeys to get them to fall out of trees so they can eat them. Okay, so it's highly dangerous medication, whereas Versed is just a sedative, and I can't remember if it's a benzodiazepine. I think it is. And so there was a patient in an MRI that was feeling quite agitated, and so she administered vercuronium instead of Versed, and the patient died. And she was charged with homicide, and she faced up to 8 years in prison. She lost her nursing license, and the hospital completely threw her under the bus and completely washed their hands of any responsibility. So an investigative journalist came along and found out that Versed and vercuronium have similar packaging and labeling, and they're all handled by this drug machine. The machine delivers drugs based on the first 2 letters of the drug name, and the nurses were regularly told to override the safety checks on the pharmacy machine because they had software problems. The pharmacist who was meant to review every medication was unavailable, and Redonda was overworked and then tasked with supervising a visitor. And so this was 100% not Redonda's fault. Admittedly, she was the one who actually administered the medication, but there were so many things in place to help her fail that the hospital should have admitted full responsibility, offered love and support to Redonda instead of letting her potentially go to prison. And so what ultimately happened was that she lost her nursing license. She'll never practice again, and she was sentenced to 3 years of probation and ruined her life. And so it ruined her life. Obviously, it ruined the patient's family's life. It ruined the patient's life. And so clearly this was a situation where the hospital should have stepped up and taken responsibility. So second victim syndrome, in summary, we need to recognize that mistakes happen, and we need to use every mistake or near miss as an opportunity to improve. And so if you have, near misses are the best things possible, because not only is the patient not hurt, but it points out a problem or a systematic problem in your practice that then you can solve. And so you should actually get quite excited about a near miss because it's an opportunity to improve. You need to make practice changes to reduce errors and to support clinicians and other team members. Create a checklist for when mistakes happen. Be transparent with owners, team members, and yourself before and after the procedure. Institute a culture of safety where team members feel safe to discuss causative factors and to self-report, and institute a culture where team members feel safe asking for help intellectually, technically, and emotionally, and also institute policy where you don't tolerate gossip or yelling in your practice. So that's pretty much all I have to say about that. I will stay on for a few minutes to take questions or comments that you might have. So I'll just give you a few minutes, and then this lecture will be available on the Vet Align YouTube channel. And so I would encourage you, if you think there are other team members in your practice that might benefit from this, that you send them a link. Also, please don't forget to subscribe and to turn on notifications so that you'll get a ding on your phone the next time I live stream. I have a busy day tomorrow and a busy week at Melbourne Vet Specialist Center, and so I do hope to provide some live streams over the next few days. And so again, thanks so much for watching. I will stay on for about a few minutes to see if anybody has any questions or comments, and if we do have questions or comments, I'm happy to answer them in real time. So we'll just give that a couple of minutes. I should come up with a joke or something while we're waiting. Let's just go through the comments here. Hello, Doc. A thumbs up from Matt. Just a few comments saying that they could hear me and see me. Good morning from Pakistan. I am from California. My partner and I follow you. We have learned a lot from your videos. Thank you so much. Hello from, good evening from Texas. Tony in Melbourne says, I spare the clinician too, and they spare me. Time off is sacrosanct. Really good. Hello from Romania. Grateful, blah, blah, blah. Thank you. 2 a.m. in Scotland. Nice to see you discussing this important aspect of our vet practice. We face a lot of issues in our country. And I think, Dr. Usman, you are in Pakistan, if I'm correct. And so I think that that's a very important issue everywhere in the world. I don't know of any country that does not suffer from mental health issues with veterinarians. Hi, Oklahoma, Boston, Ontario. So the consent form templates, I don't know that I have that available. I'll have a look, and if I can make a link to it, I'll put it on the community on VetAlign. But also, you can just go back and review the lecture and then take a photo or a screenshot from the lecture at the point at which I show you those consent forms. All right, well, I'm going to go ahead and wrap it up. Thanks so much for watching. Again, don't forget to subscribe to our channel, turn on notifications so you'll get a ding on your phone the next time we live stream. And we will see you